is Oteto Guguyu from GNP+. I'm here with the network leadership from people living with HIV. I'm here with, I'll let Tariq introduce himself and then, yeah.
Hello, everybody. Masa al khair. I'm happy to be with you here with GMP Plus for this great initiative, a series of podcasts. And I'm Tariq Alawi. I'm the director of program of MENA Community, the network of people living with HIV in Middle East and North Africa, and based in Morocco. And happy to be with you and with my colleague from Zimbabwe.
Thank you so much, and thanks Otete, and also thanks Tariq. I'm Tatina Makoni. I'm the executive director for Zimbabwe National Network of People Living with HIV, and I'm based in Zimbabwe, Harare.
Yes. So the HIV response movement has been disrupted by the recent cuts in funding that we've seen in America and the rest of Europe. We're here to talk about, we're here in Nairobi to process what has happened and to sort of just to reflect what has happened and find a way of moving forward. So with Tariq, you're coming from the MENA region. I understand that you guys were not necessarily affected by the cuts, but you probably even experienced it before. So now that the world is experiencing this, I think you guys have a lot to share on just how people can go through this. So can you give us an experience of how your PEPFAR funding was stopped and so that people who are experiencing this right now can reflect upon what you went through before?
Well, as you said, as a MENA region, so we are at the moment or at the current situation, we are not on a direct shock or direct surprise. This surprise and this struggle will leave it maybe decades ago. And we have to go back in the beginning of the PEPFAR, one of the biggest funds for HIV epidemic. And since its beginnings in 2003, the MENA region have never been a priority zone for the PEPFAR fund, while some very modest support for basically two countries, Morocco and Egypt. Noting that there was no core direct support, there was only some technical assistance, and as I said, very modest one. This support has been definitely stopped in 2015, and officially 2016, the MENA region definitely disappeared from the strategic plan of, or the strategic regions priorities for the PEPFAR fund. From 2003 until the definitive freeze or exclusion of the MENA region, we have had many alternatives, and some of them might be a coincidence, was the arrival of the Global Fund. And the Global Fund, as you know, it arrives in the beginning of 2000, and like the example of Morocco, it arrives in 2002, and in many countries comes after. And I can say for us that was one of the best alternatives that we could have at that moment, because not only the Global Fund came with the treatments or something. No, it was like a full package, financing, prevention, and treatments, and also advocacy work. And one of the most important action that was funded by the Global Fund was the community movement, or the community encouragement on the empowerment of the community, which gave the community more capacities to navigate and to discover and to connect more globally with other donors, with other countries or regions who has big practices. And the results that we have, for sure, the lake of the PEPFAR is remarkable, but on the main pillars, which is the prevention, treatments, and advocacy work, it was replaced by the Global Fund. So we are here, we fully understand what the other regions and countries are facing now, with no clear vision or alternatives. And not because the MENA region is not concerned by the PEPFAR freeze, but as a community lead, civil society, and also part of the global movement, we are here to show solidarity, to participate with our voice in advocacy movement, and also if there is any action needed, we are here to do it, and also to share one of our best practices is how to find alternatives.
Thank you. But Makoni, I understand for you, like most of the other sub-Saharan African countries, we are very much affected by this freeze. So tell us about how the networks are coping with the current freeze.
Yeah, so I think that's very true. So for us, we've been hard hit. There's a lot of anxiety that has also triggered a lot of mental health. So to bring into the picture is that PEPFAR has actually supported the Zimbabwean health system since 2006. And over that period, it has put in over 1.7 billion in US dollars. Per year, it supports over $400 million, which is quite significant. But because PEPFAR is also made up of other wrap-around services, so it's not just the amount of money that is coming via HIV, but also other support mechanisms in nutrition. Some are also looking at GBV. And if you add the sum total, it can add up to over 600 million in a year, so which is quite significant. So our case is that much of the support is donor funded. So there's a heavy reliance on donors to provide the necessary healthcare. In Zimbabwe, one of the things that we have achieved over the period is that we have become one of the countries that have reached the 95 targets. And because we are 80% funded by the donor partners, it means that we also owe that gratitude to the donor partners, including PEPFAR mainly because if you also look at Global Fund is an amalgamation of different funding streams, and one of them is the United States government. So even within Global Fund, there's also American government. So stopping of American funding is not just affecting PEPFAR in silo, but it's also even cutting across also to other streams, including Global Fund. Partners, including even Chemonics, which provide even the logistics, they also do the TA even for Global Fund. So the impact is quite diverse, is quite significant, it's quite ubiquitous. So in our case, I would say in terms of programmatic level, we have started to see disruptions in services because the human resources for health are being funded by external partners. We have also seen sometimes also people, we are also getting multi-month art dispensing, also starting to get even lesser art refills. And because of that situation, and Zimbabwe, from our last stigma index study, which showed that stigma and discrimination actually increased from 65.5% in 2014 to 69.7% in 2022, which is quite alarming and is also quite unacceptable. We have started also to witness more incidences of stigma during also the USG stop work orders. As a network, we are collecting the data, including also this issue that I'm also quite able to also to give you this data, that at real time, people living with HIV are in distress, they are in panic, and the mental health among people living with HIV is also quite compromised. And it also has got a domino effect in terms of ultimate health outcomes. So I think in terms of that perspective, it's really a clarion call for everyone, including communities, also to come on the table to ensure that we come up with solutions to the issue.
Yeah. Tarek, we always knew that we had a target of ending AIDS by 2030. So what is happening is something that would have happened, at least not necessarily now, but at some point. So for the HIV movement, especially for you who had already experienced the cuts before, what do you think about the organization towards beyond 2030, getting HIV sustainability beyond 2030?
So to be honest with you, I always say maybe the currently, as I said, we don't have a direct impact of the PEPFAR freeze, and maybe we have symbolic impact by USAID freeze, but the whole situation make us in struggle and thinking that nothing is guaranteed now. So that's the point. We were recently in a global fund regional platforms, and during the G-Fund meeting, and we say that who ensured us that what's happened today with the PIPFAR will not happen with the global fund, knowing that the US government is one of the biggest donor of the global fund. With the current situation and before, the vision was not always very clear because of the other challenges that the HIV issue is facing. Because as I said, there is not only the treatments or the healthcare. There is the stigma. There is the economic independence. There is the social needs. There is a lots of needs, either for the people living HIV and for the community itself. So, in a very particular region where we have been excluded because of the very low prevalence, but a low prevalence globally in the region, but concentrated in key population. So what makes us afraid and concerned about is what's going to be the engagement with the key population. And when we say key population, we're speaking about men having sex with men, we are speaking about sex workers, we are speaking about drug users, we are speaking about indigenous and many vulnerable population. And with the nationalism that we are feeling now, we have to ask this question. So in this nationalism movement, like previously within the global protection or the global support, the key population was facing challenges, but what about now, where the global support is more and more disappearing? So I will not be pessimist, because the HIV is here since nearly 40 years, and we have faced a lot of struggles. But to achieve the 2030 goals, I think we have no choice apart of bringing our efforts together. One, to save energies and to save funds, because we have very low funds. So the most important now is to collaborate more and to learn from each other to avoid double expenditures of funds.
Yeah.
And so we have no choice than to work together, either at regional or global level, and even at national level. So that's the vision.
Yes.
Yeah.
So, and Makoni, as Tariq is telling us, I think we're come at a point where even as donors think of coming back, we need to change the way we have been funding the HIV movement. And right now we are talking about transitioning from what we used to have into what we are trying to think of what will be there in the future. So if somebody is seated in somewhere and is a donor, what are some of the things that are urgent and should help in the transition?
Yeah, so that's a good question. And I think from the start, you need to acknowledge that this is a crisis. And how you respond to a crisis is different when you respond to a normal situation. For a crisis, I think we all expect to have contingency plans to be in place, of which most of the countries are also not having those in the place. And also, we have also not learned so much in terms of the past emergencies that have existed. Before even these challenges in terms of funding decline, we also had COVID. And for Zimbabwe, we also even had a fair share of cyclones. But throughout that, the lessons that we've not drawn enough lessons out of those adversities that have affected us as a country. So I expect for the governments and also other multi-stakeholders to come up with contingency plan, which will feed into a broader disaster risk preparedness plan, and then which will also usher us into the sustainability roadmap. We were lucky that we had started developing our sustainability roadmap. We had done module A and almost on module B, and we hope that we'll actually put a nail to it. But having a plan in place is one thing, but the financing aspect is critical. So there are other stakeholders that are critical, which is also the ministries of finance, and also ensuring that the private sector is playing also its fair share. And because our economy is also highly informalized, there's also a key role for the informal sector to also contribute towards the broader health delivery in the country. So I expect those quick reactions. But over and above, I also expect dialogue among different stakeholders, ministries of health, the National AIDS Council, the people living with HIV communities, and other STO donors to come up to a consensus in terms of the roadmap, and also how do you also take the country forward. Then I quickly expect also political will and ownership of healthcare, because health delivery is part of the Constitution, is part of our socio-economic rights, is part of the 2013 Constitution. And also because the government of Zimbabwe also ascended to the Abuja Declaration, which actually made it a key point that they also have to provide 15% of resources towards healthcare, and of which that has not also been being realized. So I think the political will is key to ensure that we realize that. But from a community, we also have a key role to play to support the government to be able to deliver. And one of the things is that also to continue to provide those low-cost models. As communities, we responded even better in COVID. No one knew what to do when COVID struck, but we had to rely in terms of our natural community systems and community intelligence to navigate the situation. And then later on, we actually started also to see the support from government and donors to fight COVID. And I think communities, we have those low-cost models. We can also continue to provide a hand when it comes to task shifting. There are other activities that communities can actually do to support the government. For example, issues around treatment, literacy trainings, adherence, tracing and tracking of defaulters, and sometimes also even issues around community viral load monitoring. These are some of the things that even communities can actually do, and even do it better, because we know who is doing what, who is living where, who is living with HIV, and also to continue to provide the peer support that people actually need. DSDs on their own, one of them is actually the off-card model, which is the out of facility art dispensing model. It also makes it even easier for us also to provide the medication to communities outside the facility, so that in Zimbabwe, which is actually being affected by a lot of HRH attrition, we don't also put a lot of burden on the healthcare worker, which is providing the services. Yeah.
Yeah, just to continue about from where my colleagues finish, it's I mean, we always learn from crises, and one of the last crises that we have, it was the COVID.
Yeah.
And as said my colleague, the best placed party who did manage to ensure the continuity and sustainability of services was the community, because they know the ground, they are the frontline army, so they know directly how to reach the people who are in necessity. So that's one of the recommendation, if you want to really to navigate and to learn from this crisis, is to give more responsibilities for the community. But before to give them the responsibilities and to give them the space to work, we have to recognize them as a factor in this epidemic, especially when it comes to key population communities. Secondly, at national level, our governments and our national stakeholders, including finance ministries, health ministries, industry and trade ministries, should be aware to wake up a bit the national domestic funds. The other solution as well that we always forget, or maybe we don't insist a lot, is the national production, especially for treatments. Now we know we are in Kenya, which is one of the biggest producer of pharmaceutical in Africa. We have South Africa. Morocco did well during the COVID with vaccination, with the prevention tools. We know that Egypt now is producing its own treatment for hepatitis. So I think we have to think about this issue and about the self-sufficiency. Sorry for my English, I'm French speaker. So, but for the self, because it's time to, and it's not new because the ground is ready. We do have the MENACAB I think there is the Africa Cup, which is a coalition, which is a group, a committee working on intellectual property and on international trading of pharmaceutical. And here bring me also, at this moment of crisis, we need engagement of big pharma, because for years they have made benefits from our IVs and from all other treatments. So it's time maybe to sacrifice and also to ensure, at least for an emergency period, here we are speaking about life-saving treatments. So for decades there have been benefits. I think it will be not very hard to sacrifice, at least just to have like a transition period. I know now we are speaking like a very commercial and a very economic language. And we have also to switch our language to speak. Because when we say that, we have the example of South Africa in the 90s, when HIV epidemic, how it affects the whole economy of the country, because they lost architectures, they lost teachers, doctors. So if we really focus on saving lives, we are saving the society and we are saving the economic pillars in our countries, and we are saving the production of our national production. So this, and I really insist on to provide safe and secure space for the community to work, and why not to start to delegate some services to the community with collaboration with national stakeholders. And I think if we bring together all this effort, we can navigate this crisis and we can achieve one or two of our goals for the 2030 achievement.
Yes. And they usually say you should not let a crisis go to waste. We also know that we were not necessarily doing so well in terms of the HIV movement. The numbers were still high. A lot of people are still out of treatment. So what can we change in terms of how going forward, how the HIV movement is structured in the long run now, beyond the transition now, if we get beyond the transition?
So I think, So for me, I think looking back at systems is quite critical, because I think in most of African countries, issues around the surveillance and documentation needs also to be a bit more tight to ensure that there's accountability in terms of resources allocation. I think there's need for better precision in terms of management of stocks. We need also to be frugal with our resources. But in most instances, like for example, in Zimbabwe, I know that the electronic health record has not yet been in place. So because lack of a comprehensive system, it means that there's going to be duplication. There are also going to be seepages along the chain. But I think going forward, we need also to strengthen our surveillance systems and also our monitoring systems. But one of the things also is also to ensure that we monitor the stocks, so that we also don't have stocks that are also expiring along the way. And also ensuring that some of the things that communities can actually also do will also be passed out. We were lucky also that we had started the social contracting model as a country. And I think it's one of the models that most African countries can also learn from. Yes, ours is not yet perfect, but I think it's already showing signs that if it's actually strengthened, it can also provide the momentary reprieve from some of this financial austerity. One of the things that we are receiving resources from government, and the resources are also helping us to be able to reach out to communities, to do the adherence, the tracking, to issues also around community engagement, which is also quite critical. And it's one of the steps that also government is undertaking to ensure that we all take a place in ensuring that the HIV response is multi-sectorial.
And now that we are experiencing this, I think this moment is calling us as leaders of these networks to even reflect upon our leadership and how we want to go moving forward. So I just want to get a little bit of what do you think will take for leadership to, what kind of leadership is needed for HIV to move forward? So I'll start with Tariq and then I'll finish.
So
It's not an easy one.
It's not an easy one, but we have to reflect.
So I think to ensure a great leadership, we should ensure a clear long-term vision, because everybody now is speaking about transition, and the transition, I will say it openly, even with the Global Fund, we had always this alarm saying, okay, transition. So, I mean, as leaders, as community led, you are working, but you have always this alarm who is saying at any moment you are asked to prepare next. So if we say our program, they are like 1 year, 2 year, or 3 year programs or activities or projects, which we didn't give a long vision term. So maybe we should work on long-term protocols or strategic. I mean, even more than 5 years, at least 5 years. And also to ensure, now, for example, let's be honest. Now, I was, for years, some NGOs or networks are providing services to community, are providing salaries for people who work for this community. So if we let them now, they are not facing only the lack of funds, but they are also facing the needs of the community. So I think we have to think more on long terms, and there is another thing also that it's important, is the decolonization of funds. Unfortunately, what we have facing, let's say the middle income and low income countries, that usually what we do receive, they are pre-apportés, prepared. Yes, pre-apportés. So projects. So, but which means at the same time, community-led organizations are working with some private donors with more flexible action plans based on the priorities. So it's very important to communicate with the community, to communicate with the key population. What are the priorities? The priorities are not what's designed in offices in Geneva and in New York or in London. No, the priorities are what comes from the ground, from the community itself. I can tell you easily that if you assess to one focus group of people living with HIV of a key population, you're going to have a work plan for maybe 5-10 years, because it comes from the real needs. So that's the things. So just to summarize, I think we need to focus more on long-term strategies, and also to ensure the sustainability of activism and leadership. I take the example of the MENA region. Many of activists are tired because of the oppression, because of the change in flow, because don't forget that we are working in a taboo issue. HIV maybe it's not a taboo, but what's related to it, the key population that affects, it's living in struggle. It's facing anti-existence laws. So we have to think, and maybe the best practice is really to think on a combined strategy that left nobody behind, and also that includes everything.
Yeah. No, I think I resonate with what Tariq says. But I think also broadly, issues around public finance tracking is quite key. Because being a leader, actually, and I've got maybe 1.3 million people looking up to me, it's always nicer and easier to point at someone. But if you are the one now who also wants to give solutions, it's not as easy as that. But I think from our end, in terms of policy level, what we also strengthen is to ensure that we track all the resources that are coming, that are also being dispensed in the from the fiscus, how much is also getting to the communities, so that we monitor also who gets what, when, and how. And also another aspect really that we also want to build on, like what Tariq mentioned, that there are these pilot projects that we've already started, and one of them is the telehealth. because sometimes there's no need for someone to always go to the facility. So we can still package it through our virtual platform, the Tabular platform, where we've got already dedicated medical doctors and mental health specialists to assist people at real time without them also suffering the out-of-pocket costs, including transport. So we'll cut some of those expenses by providing the telehealth. But I know in terms of the penetration of terms of mobile phones in Zimbabwe is almost plus or minus 36%. So we'll still cater for some, but we also know that very well there are still some people who still rely on the ordinary mobile phones. But at least we'll provide this differentiated care. I think also in terms of the leadership, we also have to ensure that we strengthen our response. But this issue is not necessarily about having options. If you are on a life-term support in terms of medication, it's not like you're picking one meal to the other. This is something that you have to take daily. So there are no options around taking of medication, but we also try to look in terms of other funding streams, including also looking at the Scandinavians and other EU countries to come into the table to also to support. But also we're hoping that also the American government and also the Global Fund will also continue to provide the services. But I think in terms of healthcare delivery, someone is responsible. Someone needs to be accountable for the livelihoods of their people, and that is government. So we still need to also to take government to account to be able to provide the same way they are also providing resources for defense, the same way they are providing resources for it could be education, it could be any other support. Yeah. At least it should be an equitable access to a holistic provision of services to people. But taking of medication is neither here nor there. Someone has to take it on a daily basis, and you cannot skip a meal. So I think government also has to come to the table to ensure that everyone gets the medication at least. Also, as networks, we also continue to provide in terms of other HIV-sensitive social protection programs, including assistance with nutrition and palliative care.
So thank you so much, gentlemen.
Just before the finish, so
definitely.
Yeah, I while speaking about the end of HIV, there is a key word which bring, treatments as, IVs as treatment, as also as PrEP. We have to mention and we have to focus more and to push for research for the long-acting treatments, either as a treatments and as PrEP. As this, we will reach the U, which everybody now is working on. So let's also take in the heart of our concerns the long-acting treatments and PrEP. So that's also a very important point to ensure.
So thank you so much. Thank you so much, gentlemen, for sharing your stories with us. You're here with us this is GNP Plus in Nairobi, the PLHIV Leadership Summit, where we're looking for solutions and a way forward from around the HIV funding crisis. This has been your host, Amotiato Guguyu, and Tariq and Makole. Thank you so much.
Thank you so much. Unfortunately, I cannot say Hakuna Matata.
You can say it for you.
You can just add it there. And tutaonana baadaye.
But I can say shukran.
Shukran.
Shukran jazilan. Thank you.